Okay, welcome to another Manual Therapist vidcast. With me today is Charlie Weingroff. Um, he is basically the strength coach and physical therapist version of Wolverine. If you guys know who I'm talking about. I think everyone who's interested in movement or strengthening, which I assume are most people in our profession and outside of our profession as well, should take his stuff. I was honored to be a guest at one of his courses last year, and I learned a heck of a lot. So, Charlie, could you tell us a bit about yourself and why you call yourself a strength coach first and a physical therapist second?
Yeah, it's ironic. I put a picture of in the new X-Men movie. They put a picture of Beast up on Facebook, and someone, I don't forget who it was. They said I remind them of Beast, not Wolverine. Beast can do some really cool stuff, and he might be kind of smart. I don't know how smart I am, but that's ironic that you chose
Yeah,
to compare me to Wolverine. But
I just
I
mean like height and build.
Yeah,
It's
there
height
you
and
go.
build. But
Anyway,
yeah, all the split stuff and the Van Damme stuff you do actually is more like Beast. That's true.
yeah, all right, whatever. You can do worse than either of those two
Right.
characters. But
That's right.
I've always I went to undergrad and I always had it in my head to become an ATC, and then I guess because my advisors kind of guided me a little bit. They're like, you should just try to go to PT school. My initial plan was just go get a master's in kinesiology or ex-phys, and that's kind of at the time in the late 90s that was the typical course of action for athletic trainers. At the time, there was a nice master's, PhD kind of program at University of Virginia. Some really, some high-level individuals, and there probably still is. But I went to PT school instead, and I had always had the intention of going to PT school to become a better and/or more marketable athletic trainer. Now, faculty during that time didn't really much approve of that, and I was at the time. I think I went to PT school. I was 20, 21, and 22. I was kind of a little ahead during my education stuff, so I didn't know to keep my mouth shut. But when I my second year of
You
PT
know that
school,
now?
no, really, how about that, right? Me
Yeah.
not being able to keep my mouth shut, who would have thought of that? But I was just very blessed. I was able to get an athletic training job before I graduated PT school in minor league basketball. And head coach was Rick Barry, assistant coach was Clifford Ray, blah, blah, blah. I graduated PT school in May of '99 and was in the NBA with the New Jersey Nets in October. And again, obviously all who you know, but really was able to be in professional sports for the good part of the next 10 years at that time. And I had started off as an athletic trainer, but I always been lifting weights. Even at the end of college when I didn't play baseball my third year, because I graduated in 3 years, I got into powerlifting. So even though I was still a physical therapist and athletic trainer, and that was my primary skill set, I'd always been a hobbyist in strength and conditioning. So being good at what I enjoyed to do for my recreation brought me to lots of clinical information. And as the years went by, I got an opportunity to get back to the NBA after being back in the minor leagues with the 76ers. And again, my first opportunity was to come back as an athletic trainer. But I guess given my build or just whatever it was, it turns out that the players, yo, come on, Chuck Wagon, let's go get a workout in. And I knew enough to put, a very undertrained individual like an NBA athlete through a workout. And sure enough, next year I'm the head strength and conditioning coach, where perhaps then my education started to take me a little bit more towards traditional strength and conditioning. But what I was finding was I had found the movement-based approach as a physical therapist in terms of Shirley Sarman. When you find out Sarman, you try to find collateral messages, and I found Yanda. And then when I found Yanda, I found Gray Cook and the functional movement screen. And what I found was this movement-based approach was the most valuable tool to be a strength and conditioning coach at the NBA level. at the NBA level, it's not really getting these guys to jump higher or run faster, et cetera, et cetera. It's about keeping them put together. And in my opinion, the movement-based approach, of which there's now varying levels and different commercial models, et cetera, this was what helped me do my job very, very well. But as time went by, I kept finding that the same things that help us jump faster are the same things that help us move better, which often are the same things that help us get out of pain. And for me, even when I was in the minor leagues, if nobody was hurt, I had to be the strength coach. So I learned about warm-ups, and I learned about proactive types of training. And because I was a physical therapist, there were certain techniques that just had resonance to me. It's like, why not try this? And the more that I started to put this all together towards the end of my time in the NBA, and then when I moved back to New Jersey, and then went to the Marine Corps, in terms of what I did with Marine Corps Special Ops, it just became simple to me, and I really started to funnel. Like, the only reason anyone, in my opinion, should be doing rehab is so they don't have to do rehab anymore. So, like, I'm teaching a course right now out here in Palo Alto, and I'm like, I don't know if this will show up on the screen, but I mean, I think of training over here. Like, this is the full program. And for someone that has back surgery, of which I feel competent to be working with them, the program goes like this. And it kind of finds its like, everything that I'm doing for someone in back surgery is so I can get them to deadlift as soon as possible. Now, that's not very soon, but that's just how I look at things. The whole idea is to get back into aggressive fitness. Well, what if the person doesn't want to get into aggressive fitness? Well, number one, I don't typically work with that person. And number two, the reason they probably have back surgery is because they didn't have fitness, or they had wrong fitness in the first place. So that's just the niche in the world that I live in, is that the only reason to do anything that's rehab or remedial is to get us into ass-kicking strength and conditioning as quickly as possible. Now, that doesn't mean you're going to be doing things that violate post-surgical protocols or pushing through pain. What I'm saying is that when you have that movement-based approach and you respect that the body moves in patterns, some patterns are not under threat perception. And these patterns may have the authority to develop capacities, getting more fit. Other movement patterns that are not under threat perception, may not. They may be appropriate for competency training. And other movements that are under threat, there's a whole nother skill set of patterns of interventions that would be appropriate for people describing nociception. So, you just look at things in terms of patterns. You can now blend. Doesn't mean that the same person has to do it, but you can now blend a competency movement strategy program with a capacity movement program, and dealing with pain. And you can do this all at the same time if you honor patterns and look at what we know about pain and motor control, et cetera, et cetera. So for me, the goal is always to get to some kind of fitness program. That's how I consider myself a strength coach that knows how to deal with pain and serious dysfunction.
Right. And obviously, the population you work with is different than what your average PT works with. But I do think you can take away a lot of what you get from the strength and conditioning world and apply it to almost any population, because most people just need more fitness. They absolutely need fitness, and I think that in the ortho world, we have our own gurus, and really none of them look at that kind of stuff. So that's why I do want to bring more attention to your particular approach and basically lifting heavy things.
Remember too,
I never would have thought of using kettlebell carries for scapular stability, but I've turned a lot of people onto that on my blog after taking your course, and I implement that in almost any population. And as long as they have enough range to do it, and they can do it without any pain, I've seen way better approach or results with that for scapular stability rather than doing Ys and Ts, which all I ever did with Ys and Ts is train doing that movement, but they still had winging. I just never had any. I don't care what the EMG studies show. I just didn't have as quick success with that.
Yeah. Well, remember too now, and obviously sometimes my message we made a joke the other night. We had a big dinner with a bunch of SFMA characters in Newark, and I'm like, yo, just because I talk loud all the time doesn't mean I don't know what I'm talking about. So, I think sometimes people are put off. All right, well, that dude bench presses 600 pounds, so what the hell does he know? And that's okay. Like, so when we say lifting heavy things, heavy is just relative for different people. And the fact of the matter is, when you believe in lifting heavy things, this becomes easy. But most rehab people don't do it themselves. They never did it in their life. It's not questioning their altruism. It's not questioning their techniques. But I will say this: how do you link capacity training, competency training, and removing threat perception? The answer is the autonomic nervous system to all three. So the target organ is always the brain. It's the brain that allows pain to change. It's the brain that allows us to develop more ideal motor control, and it's the brain that allows us to change protein synthesis and different cellular adaptations of the muscles to improve fitness. Golly, this is all the same thing. I could use the same strategy in how do I just from a principle basis. The systematic approach is to address the autonomic nervous system, and I can get all three of those things. Maybe I use different interventions, but if I can beat the autonomic nervous system and take it back into balance out of threat perception and change cellular adaptations, I could potentially get all three at the same time for the right person. And then when you just prioritize things. We obviously cannot train capacity in pain. We know this, and that's not what this strength and conditioning approach to rehab is about. It's about prioritizing, threat perception, motor control, and then capacity. Because what is an enormous piece that is missed is that the better your metabolic capacities. So this is your endurance and your strength, and different expressions of power. Strength is just power is your strength over time. The more robust capacity you have that you have developed honestly with integrity and not destroyed your body, the more tolerance you have for biomotor skills. That's fact. That's not, so you could do the best job you want of doing whatever you do to make the shoulder feel better. You can get them moving pristine. The fact of the matter is, as soon as they get tired or lift something heavy, getting tired and lifting heavy is a part of everyone's life, then all of a sudden their body breaks because they didn't have any capacity. Even though their body could do certain things, it doesn't mean that they will do certain things at different intensities. So to suggest that, well, I just treat pain. That's the population I work with. Okay, that's what you're good at, but you have to at least express to the patient that, look, you know what, this is something you should be doing. At least you can go to bed at night saying, okay, you number one, you admit you're not the one that has the skill set to do it. You don't have to be. But we can't say that stuff doesn't matter, and we certainly can't look down upon an alternate strategy when we're all measuring against the same audits of pain and quality movement competency.
Yeah, I think one of the things my business partner and I realized when we attended FMS for the first time a few years ago is that your average PT doesn't take your patient far enough. And we do think it is fine. And there are some people, like I have sedentary office workers who all they're ever going to do is walk from the car to their computer and then to their computer back to their car and then back to their computer at home or in front of their TV. And that's cool. And those are the guys who I always say, I don't do the full FMS or I don't do the full SFMA on them because they're never going to need that movement. But you're right. You know what? They should be doing it. But sometimes I can't convince them that they should. But I know that you and I disagree on that, and that you would always do the full SFMA or the full FMS on them. But that's just where you and I differ because I go to MDT first and then SFMA second.
It all comes out. It all comes out in the wash with that particular suggestion. Because if someone has pain, you're going to treat the pain, which is your MDT approach. Whatever. It's like the chicken or the egg that comes first. It's but the suggestion that if you are interested in treating the pain, you may find a very distant part of their body that is contributing to their pain whether it be through a movement approach, whether it's through radiating pain, whether it's through referred pain, to not examine other areas. Doesn't even have to be in the first session. It doesn't even have to be your primary attack point. But I think it's a very myopic approach to not utilize the full picture. Even though you might not intervene at the full picture, I think it's still incumbent upon us to be able to see everything. It's like, all right, I run in the house and I'm a fireman, and I see the big fire coming out of the stove. So I focus all of my energy right there at that time because it appears to be the primary problem. But maybe I don't think it's that big problem, and I actually scan the whole house, and I see that there's something else that's feeding it. Maybe I'll beat that first. It's like there's no right or wrong way, whether I attack pain or I attack the collateral contributors. There's no right or wrong order to that. What I would consider myopic is to not consider these other locations of contribution just because there's an assumption that the person won't use them. Because the FMS and the SFMA are not fitness tools. They're human movement tools. And the value of establishing a movement standard of non-painful movement via the FMS, this is not to get someone into fitness. You can use it as such, but ultimately the FMS is telling us that what parts of their daily life could then restore the threat perception that you so diligently worked on to remove. So I'll take it back to this unfortunate discord between where to go, MDT or SFMA. It doesn't matter which one you do first. What matters is that after you have adequately restored a pain-free movement through the spine and they're basically as good as new. And then the sensational example is that they have a right-sided dorsiflexion restriction, of which the repeated motions testing does not account for. Is that at least fair so far? Like, is this an accurate appraisal of traditional MDT?
Yes, traditional MDT, absolutely. It's just
okay,
that,
yeah, traditional MDT. So then I would continue. I would say that instead of having this, your hip hip hooray, you've now beat photo or whatever foolish outcome measures you choose to use, and the person is off on their way and their back feels great because MDT is an excellent, fantastic, efficacious approach to changing pain. However, I'm not going to do the FMS on them, or would have done the SFMA and gained the information when the pain is gone, so that I can get them back into fitness. They will have to squat. They squat when they go to that chair at their desk. They squat on the couch, and they squat to get in their car. They squat to go to the toilet. And what is going to happen when that depth of squat meets the restriction in their ankle? They will repetitively flex through their spine in a large portion of the population. They will then restore that threat perception, whatever is causing it. They already proved they were intolerant to flexion of one group of individuals that MDT can recognize. They will then continue to become flexion intolerant, and it had nothing to do with what MDT is good at doing. It does not evaluate the ankle. So whatever your strategy is, that person is now going to keep coming back to your office unless they actually realize, you know what, this person's really good, but there's something else going on here. And that's that. So now whether you don't do the SFMA at all, you just do MDT, it's a home run and pain is gone, then you do an FMS. And then you find out what MDT did not tell you. You don't go to this biomechanical assessment just because MDT didn't work. That's like somebody just looking for an excuse to stick with their emotional connection. Or you could do the SFMA first, bucket your painful patterns, MDT approach. Then bucket your non-painful patterns. Maybe you work on those as well with manual therapy or your own active exercise skills, or you tag out to a fitness professional or a different medical professional that's good at that stuff. And then look, you're done. Now the person goes to sit on their chair, sit in the car, sit on the toilet. Their ankle dorsiflexion is removed because you found it. Then they don't come back ever. That's the outcome study that maybe takes 6 sessions. It doesn't look as good as the 2 sessions, but now the person has a better expected long-term outcome. And that's the message. It's not the order, because I just gave you an example where you don't even have to do the SFMA. You got to do something to find what your bread and butter is not looking for.
Right, right. And I do totally get that. It's just that for me, MDT is first because I do treat the pain first, and then I do FMS for clearing or SFMA for clearing, and I do try to clear up adjacent, distal DNs, and I do like Ray's message about treating distal DNs because treating something that's distal, also you're less likely to flare them up and cause perceived threat. So I do them as clearing, and I especially go to them right away when MDT doesn't work at all. But I don't let someone go for the most part. I do try to suggest. I always suggest, hey, these are other things that we can work on. But you know what? I can't keep them all. I can't always keep them. So
yeah, no, and that's
I try to make suggestions.
The thought process is really what at least I'm about to say what I'm trying to teach. But let's say I do an SFMA first. You better believe on day 1 I'm going to treat their pain. Especially if it's someone that doesn't have complete confidence, because I can do all I want to that ankle, and in the short term, the chemical response in the spine is not going to change. The person is not happy. I think sometimes maybe there's this assumption that you ignore the painful pattern in the SFMA and you just treat the dysfunctional non-painful pattern, the DN. I think that's not exactly. That might be what people are hearing, but that's not the message. You certainly have your option to treat the pain first. There's no the healthcare professional has this leeway. It has this artistic approach on does going after the stiff hip immediately change their spinal function, or do we need to go local to the spine? There's no wrong way to do it. What would be wrong is to not address everything, or at least put it in your mind that this is what I need to do to be complete. And now it's on the client or the patient to not be interested in receiving this service. That's kind of maybe a different way to explain the same thing.
Right, right. And like you said before, I think when we spoke early in the year, I think you and we just have different starting points. But I think we often end up in the same place. It's just that you probably keep patients better than I do. So, all right.
I see you smiling, but I don't know what you said. It got all garbled. But whatever it was, I'm sure it's cool. But what I like that you said is that we have different starting points, but we have the same ending point. It doesn't matter how we get there. But if you let somebody leave your office, I don't mean you personally, and you don't even think that the ankle matters because it's not what the person wanted, you're on the B team. That's unacceptable, because that person will hurt their back again, and that's unfortunate.
Right. Agreed. All right. So another thing you talk about a lot at your course, and it has all this mysticism about it, because unless you've taken the courses, and I certainly have not. I only hear a lot of people like you and Craig Liebenson and Jason Brown and a lot of guys, even a couple guys at the course I taught today. Everyone talks about DNS. You call it voodoo magic, and you say it's very, very effective. But you're also one of the few guys who've actually trained in Prague.
Yeah.
So I think you know it really well, and you're also one of the only guys I think in our area, like the whole East Coast, that is really, really certified from out of Prague. Correct?
There's a chiro also in New York City that is certified, but he doesn't do it too much, as far as I know. And but other than him, I'm the only one probably east of Chicago that's certified in DNS. Meaning you've gone through Prague and taken a whole bunch of courses, and I'm still. I mean, it's the kind of thing that just like any commercial methodology, you're never great at it. You have to keep learning and keep getting better at it, and surround yourself with as many experiences with that particular methodology. But the gravity for me is not the methodical techniques of DNS. It's the principles of developmental kinesiology that truly explain why lots of different things work. I think the, the mysticism of it is very fair, and sometimes I'll explain it via acupuncture. So acupuncture goes off of a different system. It goes off of a different rule book. It goes off of a different Bible, if you will, than how we're taught to look at the human body in Western training. Acupuncture develops energy through meridians, and Chinese medicine goes off a different manual. We know needles work, whether it's acupuncture or medical acupuncture or dry needling, but the intent of why an acupuncturist puts a needle at a certain point is very different for the intent of why I put a needle in a certain point. Maybe the acupuncturist puts it there because this is a particular point that is believed to be part of a meridian, and I'm putting the exact same point because I know that there's a superficial nerve there, and I know when I put a needle in a superficial nerve, there's immediate reuptake of oxygen and change in fibrosis of soft tissue. So the intent is very, very different. The outcome is positive either way through improved movement or change in threat perception. So getting back to DNS, the rules of developmental kinesiology are not the same as what we learn in biomechanics. They're not even the same of what we know from all of neuromuscular types of training. So it becomes very hard sometimes for people to wrap their head around it because it's going off a different system. It's going off a different set of rules, and those rules are based upon, we know that in the diseased infant, God bless that you don't know people or have people in your life that have these challenges, that they do not develop with the same milestones. They do not develop with the same motor patterns. Their joints and bones develop differently when they do not exhibit these key joint positions that is known in DNS as joint centration. So the assumption is that if you're healthy, you develop in a certain way, and you've minimized musculoskeletal issues. So the deeper assumption is that as an adult, if we reproduce these low immature positions, like lying on our side and stomach, and these what appears to be crawling and rolling patterns, and we duplicate partial patterns of joint positions that are the same as what baby does, we are able to trigger in our brain this quote-unquote resetting of neural tone. And how does this happen? There is no, I'm not familiar with any, there is no explanation. You just have to believe that it happens in terms of whatever it is that allows our bodies to reset and change pain and change tone is the same mechanism that tells us as babies to progress to vertical in the months of 0 through 14, because no one is telling baby what to do. It's just in our DNA for this control of our body to happen. This control of our body in the baby is also remarked by the same positions that the strongest and the fastest people on earth just do naturally. So it's somewhat of this reverse engineering of what babies do to change pain, improve movement, and also to have incredible power expressions. So maybe that's a little bit of a 6 to 7 minute explanation of what DNS is, but there comes, just like acupuncture, you kind of just have to believe that this works. Like, this is not terribly grounded in anything more than maybe what we can call soft science. Now, I'm far more interested in the principles of all these types of things than the actual techniques. I use them liberally, but it's not the only thing I do. So sometimes I say that everything I do is DNS, but very little of what I do did I learn from DNS. DNS to me explains why things that we do work, and that's developmental kinesiology, which is more than just crawling and rolling.
Yeah, I noticed. I noticed even at your course you teach the rolling patterns different than what they teach in the SFMA, and I assumed that it had something to do partially with DNS because just your hand and leg positionings were slightly different. But I'm sure it was a watered down version, but they seem to be easier to do than the way they were taught at the SFMA. So that's the way I present them to patients now too. So one of the criticisms I got from a couple chiros who took my course today, and they took DNS. Earlier in the year or sometime last year is they said basically they felt like they didn't have the time to put their hands on a certain point and wait for like 5 minutes, and they felt like they had to use that exclusively as a treatment. The way the instructor presented it, it's a course. You're getting someone to move in a certain pattern, but it literally took an hour to get a various point touching, and sometimes nothing was happening for 5 minutes or something, other than fasciculations. And he said that he could definitely feel like something was happening, but he didn't feel like he could only do that in terms of a full hour's visit. Do you think that's true? Do you need that much time to make a rapid change, or do you get the wrong idea with that?
No, I tell you what, I think this is likely sounds like a very fair discussion about their experience. A couple things. Number one, this methodology. Remember, I'm telling you, I'm way more interested in the systemic principles than the methodical techniques. Okay, the techniques of DNS are based in Prague, where you sprain your ankle, whatever that means, you get admitted to the hospital and you get PT twice a day. Okay, so these techniques are not, best applied in a Western training environment. Okay, that's number one. So, number two, if they took this course recently, unfortunately, my opinion is just not the same as what it was 4 or 5 years ago when I started taking it. That's just my opinion, and that's very unfortunate. I would ask them to continue to dabble and see if it works, but you do not need to see the anticipatory patterns when you try to use reflex locomotion for you to have the positive result. Now, that being said, maybe that's easy for me to say because I have all the time in the world to see the people and I get paid for what I do. So that's easy for me to say. But if you use the positions or the reflex locomotion patterns or active exercise patterns, you're simply looking for centration and you're looking for the centrated respiration response. And if you have that, you should have something desirable. Or maybe you're just, now also keep in mind, if these folks just took A, maybe they just didn't learn the right positions to see a quick response for their sample size was just the students in their class. You don't get the whole kit and caboodle right away. So that's a very fair, criticism. But maybe you just need more positions that you learn in B and C. But everything they're saying is probably very fair. In my A, we had individuals that we could take to standing, which is stuff that you wouldn't believe unless you saw it. And on using the ASIS point in one of the patterns, I played my partner's hand like a joystick. Like if I pushed in his ASIS, his arm moved, and if I let go of his ASIS, his arm fell. So sometimes the learning experience is different based on the people that you have there, but that responsiveness of the patient as a result of, I'm assuming they're concerned about reflex locomotion, which is just one piece to DNS. You don't have to make the person move. You can get a very, very positive, magical response just by changing their breathing pattern, and that's, but it takes time, and obviously you do not have to hold it for 5 minutes. I don't mean it takes time to do the technique. It takes time to become confident in something new that doesn't work off the same reasons why other things work. So this is very fair criticism. But remember, for me, I had already been steeped in Yanda. I had already been steeped in Gray Cook and learning these developmental patterns. I've already been steeped in understanding Hodges and in Joel's message. Like, these are all pieces to the DNS puzzle, and I probably have a different litmus test in my level of open-mindedness that I wanted it, and I believed it, and I see that it works, and I can say that all I want, but when you're at a course like that, and all of a sudden if I put one thumb here and the other thumb here, and you just gain 30 degrees of hip extension, seemingly for no apparent mechanical reason, you can see that it happens, very, very real. So, but at the same time, for me, my espousing of DNS also has a lot to do with stuff that they don't teach, and understanding that throwing a heavy weight over your head and watching this ideal tonic and phasic dance of your shoulder muscles, that's DNS, and they would never put a heavy kettlebell over someone's head. So this is fair criticism from the folks that you talk to, and they'll see if it's the right thing for them. Many ways to skin a cat.
Right. And I think what you said, it's probably hard to criticize any approach unless you've gone through it all. And it's also entirely dependent on who was in the class and what you saw in that class. And I could say the same thing about a lot of the courses I've been to, but that's why I always tell people not to knock something until they've taken it all and have a really good understanding of it. It's just hard to base it off of one course. So.
Yeah, I think that's I would agree with that. I do think that if you were going to be traditional and do it the same way they would do it in Prague, that's very fair for them to believe that it seems like you need an hour or an extended period of time. But you don't. You don't need that kind of time.
Yeah, well, DNS Sport is coming up to Toronto or Mississauga, actually, where my wife is from, later in the year, and I'm pretty excited about that. Should I be excited about that, or should I just take the traditional one?
No. For you or a healthcare provider, you take the traditional one. Yeah, I wouldn't recommend it at this point.
Okay.
Yeah, it's just my reputation is worth more than anything. You'll leave it at that.
Okay, no problem. Alrighty, those are all the things I wanted to cover, and thanks for doing the interview, and I hope you guys learned a lot. I would highly recommend you can check out Charlie at his stuff. I'll post links at the end of the video and also on the blog post, but basically charlieweingroff.com. He is about to revamp his course, right?
Am I gonna get more hate mail from all your McKenzie people? Dude,
hey, you know what? I get. I'm not a McKenzie purist either. And it's one of the things I teach that as a system and as a start. But like I abandoned it very quickly, and I put my hands on everyone. I'm not like an 80% hands-off guy, but they come on mine. I wouldn't call them my McKenzie people because they actually told me. They told me to come to your site and argue with you, and I was like, hey, look, we already like settled this peacefully, and I probably agreed with most of what he had to say, but yeah, there are haters out there.
I started deleting comments, and then I'm getting emails. Did you delete my comment? I'm like, yo, this is my website. What you think this is some democracy? You can't put whatever you want on my website. Get out of here, you fool. In the meantime, this is just, hey, listen, McKenzie is clearly a brilliantly efficacious approach. It is brilliantly incomplete. And if we can't agree on that, let's just talk about football. That's okay. Like, nobody's a bad person. Everybody's making money. Everybody goes home at night and sleeps and takes care of their kids. But you can't tell me, you may not like how I said it. I don't mean you personally, but that was some funny stuff. It was hilarious. And the cool part is all the certified McKenzie folks that 100% agreed with me, they don't post anything because they're like laughing at it. They're like laughing at all these zealots,
Well,
the same thing with everything.
Yeah, the diplomats who train with me under fellowship, they find it kind of hard because I tell them to look at something else. And one of the first assignments I actually got from Stanley Paris's wife, Catherine Patla, she just said, hey, you know what? Write a case about a low back patient that you got better by only treating their hip. And basically that would be just like a joint by joint. Very simple approach, right? So I give that to every McKenzie diplomat, and some of them, the open-minded ones are cool, but the very dogmatic ones are just like, well, wouldn't that make him a hip patient? No, not necessarily. I mean, but why do you even have to look at it as only one area? But they're dogmatic like that, and I understand it. They've paid. They're basically, 2 3 extra years of just ingrained training that you only need to look at the one area that bothers them, and if you only need to treat that, I get it because it's simple. But I do think it's irresponsible not to treat adjacent areas that aren't moving well. So that's why I always add a manual, and manual is just a cheat, just allows me to do something faster.
Oh, I mean, I don't even identify a use or non-use of manual therapy as part of it. I look at it as simply the assumptions that a movement-based approach is a biomechanical approach. This is not, it is a neuromuscular approach, which is very, very different than mechanics. And, it's,
Right.
the order
I
is
don't I
not.
don't teach it as biomechanical.
Yeah, yeah. The order of whether you treat pain or dysfunction, that's not the bone of contention. I remember when I first took the SFMA, and then came back for like level 2. So I was in the first SFMA ever taught. I was in the second SFMA level. I was in the first SFMA level 2 ever taught. And I remember, I think Kyle was saying, he's like, just want to make sure you guys are all clear on something. You don't ignore the total knee replacement and just train their T-spine. Like, I think that's almost what people were hearing. Like, the suggestion is that you must go in parallel. And if there is a need to put out the big fire first, I don't care if you use Mackenzie, Maitland, dry needling, chiropractic, or spread peanut butter on them. It doesn't matter. The suggestion is that if you're only using a commercial model that is based on excellent threat perception modification, you're not looking at the complete neuromuscular entity. And then this threat perception, you could probably come back. That's all I'm saying. And that's, I don't appreciate or understand dogma that is looking to be incomplete. When you take your car in for brakes, do you? I don't do transmission even though it's leaking. That would be offensive to people. But that's what they're saying. So
Yeah,
that's how I see it.
I try to teach them different, but sometimes they don't want to listen. So
No, it's okay. We're not going to save the world. But I will delete their posts if they continue to bother me.
Actually, yes. Everyone go to charlieweingroff.com and disagree with him.
Yeah, right.
Yeah. All right. Thanks a lot, Charlie.
All right, man. Very good, Erson. We'll talk to you soon.
All right.